Okay, good morning and welcome to Medical Grand Rounds. I want to start with a couple of updates before we get into Dr. Okolo's case presentation. First of all, for those of you who do not come to the hospital frequently, you should know that the opening of the new building, I put that behind me to remind myself to talk about it. The MICU has now officially moved to its new space. The MAT unit moved yesterday to its new space, and we plan to move the 5500 floor to the new space next week. I thought I'd take a couple of minutes to update you on the COVID-19 numbers. These are slides taken from the leadership update that Dr. Mayo and Dr. Bhavsar gave yesterday. So they're not my slides. I might not be able to answer all the questions, but I think they convey a picture that people need to know and understand and react to. So you should all be seeing the slide, the first slide right now that says current data and projections, our journey to date with COVID-19. As you see, we had this initial spike in May. We've been stuttering at these lower levels, and then in the last couple of weeks, things have escalated again. So these are the numbers. Within about a week, there has been about a doubling of our inpatient census, an increase from about 40 to about 90. And this slide sort of shows you the timeline of the recent events that have happened. There was a signal in the data actually here in mid-October that suggested that this was about to happen. And so retrospectively, that was correct. It was followed by the DeMay outbreak, followed by this 1A rise, and then culminated in Monroe County going quote unquote yellow a couple of days ago. So we are currently in what is defined as stage 1A, which is 80 inpatient cases across the system. The projected best case scenario is over here. So it's only going up over the next week. We will be in stage 1B, or 120 hospitalized patients by the 17th of November, stage 1C by the 22nd, stage 1D, or 160 patients by November 26th. That's the current projection. So this is what that curve looks like in numbers. This is where we were in that initial surge. We've been down here for a couple of months, and then these red dots are where the surge seems to be going now. So this is how the 1A is defined. It's not just that number of 80, it's multiple other things. It's the moving average and the slope of the curve and the number of new admissions, et cetera. We meet all those criteria at this point. So we clearly are in that phase. And these are sort of the projections of where we're going. I'm not saying we're going to have 200 admitted patients at any time. Hopefully we will turn the curve like we did the last time and see it start to come the other way. But I think in order to do that, I wanted to show this just to emphasize to people, we are in the midst of wave 2. Please take this seriously. We're back to the kind of social distancing that we were doing in March and April. So be very careful, not only in the hospital, but in your own communities and in your backyards. So this slide here shows you where our admissions are coming from. So you see the yellow here. The yellow is people who lived in the community before being admitted with COVID. The blue is people who came from nursing homes and things like that. So as you can see, the yellow went up, and then the blue went up following that. And currently we're seeing the yellow go up. So most of the infections are coming from the community. Other than DeMay, we have not had any other big nursing home events. The age of the admitted patients. So the infected patient age seems to be lower than it was in March and April, but admitted patients still over 65 is the highest group. The number in the 50 to 64 group is growing, and you see that in red. The 19 to 49 age group continues to fluctuate. So again, we are in this stage 1A. The stage 1B will lead to further action in terms of appropriately postponing elective surgeries, et cetera, projected for next week, but of course we don't know for sure. So I'm going to skip through some of these other and basically summarize by saying wave 2 is clearly here. Stage 1A of the surge was activated on November 6th, and the numbers are being monitored every day to see when we hit stage 1B. Feel free to ask questions if you would like, but I'm not sure if I'll know the answers. I don't have an infectious disease person on the panel today, but I can take the questions back, or you can ask them of incident command if indicated. So I'm going to stop sharing at this point to allow our main Grand Rounds presentation by Dr. Okolo to begin. This is a case conference presented by our Assistant Chair of GI, Dr. Patrick Okolo. So without further ado, Dr. Okolo.
Fabulous. Prad, thank you very much for that update and for the sobering idea that this is here. So without much ado, let me see if I can start this. Lovely, thank you very much. I will try to get through this. I have no relevant disclosures. I don't consult for anybody at the moment, so these are unfortunately a function of my own personal opinion. Let me start with the case and we'll walk through her pretation. She's a 62-year-old female who is recently retired. She was quite healthy, no history of non-steroidal use, even though she was a known marathoner. She was admitted after a 4th episode of GI bleeding, which mostly manifested itself as melena. Her first episode actually started in 2008 and then was clinically quiescent for a whole decade before she had 2 episodes in January and then in May of 2019, and then a 5th episode in January of 2020. She had negative upper endoscopies, multiple colonoscopies, and at least could find 7 of each variety in her medical records. She had 2 push enteroscopies to the proximal jejunum with no findings. She had had a capsule study, capsule enteroscopy study, and I'll just briefly talk about those in case you're unfamiliar with that, in 2018. And in between these episodes, she feels rather well and is virtually asymptomatic. So she, again, as I said, presented in January to the emergency room with a hemoglobin of 7.2, and some of the indices at that point suggested that she may have had some low-grade bleeding for a while. She had some microcytosis and iron studies that were indeed consistent with iron deficiency in a postmenopausal female. So at the time, she was hypotensive in spite of the number of 7.2, which we thought was an overrepresentation of where she was. She was then resuscitated and referred for further evaluation. And so at this point, you know, she's had at least 5 witnessed or documented GI bleeds, without knowing the cause of her GI bleeds, we're not really able to do much about it. So understanding the implication of the GI bleeds are clear to us, but the etiology was unclear. And so the question was, outside of the ecosystem of what she's been subjected to, are there other things that we can do to identify the source of her bleed? What is the correct sequence? What's the correct cadence of using any of these ancillary investigations to help her? So I'm so sorry, I think I went back. So anyway, she became hemodynamically stable, and I was just profoundly fatigued. She was madly orthostatic. She improved significantly after 3 more units, and was quite stable then through the hospitalization. During that hospitalization, she started itching to go home, but we managed to convince her to get a capsule study done. Here's what the capsule studies look like in case you are not familiar with them. So sorry, I'm not quite sure what's come over my screen, so forgive me. Oh my. You can sort of see in the background here. Oh gosh, I've got to take this away. I'm so sorry. Anyway, so the Travis, how do I make that go away if other people are seeing it? It's a little, let's see if I can move that. There you go. I can at least move it to the side. So basically with a capsule, it's a small camera, it's a small pill camera, and it traverses the GI tract, usually largely by peristalsis. It takes 4 pictures, 4 frames per second, which we're able to stitch into a movie that we can watch and really evaluate the GI tract, if you will. Now suddenly this is stuck. Okay, very good. She was subsequently discharged with the intent of an outpatient workup, and she went home. But 1 week after discharge, she called the after hours line, very agitated, if you will. She had a sudden onset of very severe epigastric pain. Remember, this had not been part of her presentation. She thought that the epigastric pain was related to a stressful kitchen accident that had happened. On further questioning during the kitchen accident, she had turned on the gas stove, and her husband came in about 25 minutes later and smelled the gas, and really was admonished her for turning on the gas and not being able to smell it or pay attention to this. So she was feeling quite guilty about this, and this is about the time the abdominal pain started. Unfortunately, in spite of his admonition for her to calm down, the abdominal pain continued and continued to the point over 24 hours that she became quite anorexic. She was not able to eat any further and reported no evidence of GI bleeding. She had always had melena in the past. So she was asked to come in as we couldn't quite understand what was going on. Her blood pressure was normal. She had a temperature of 90, a little over 99.5. Her heart rate was otherwise normal, a little bit high for her. Being a runner, she usually was in the 60s, but she had a heart rate of 70. Respiratory rate was 18 per minute, a little bit high for her. Again, she had no reports of melena or hematochezia. She was uncomfortable upon arrival. On examination, she had generalized abdominal tenderness without any rebound. A little bit more tender in the right upper quadrant, but she was quite tender all over her abdomen. Her hemoglobin was stable at 9.7. She had been discharged at 9.5. A complete metabolic panel demonstrated mild pre-renal azotemia with a normal creatinine, but a BUN of 34. She had moderate to marked transaminase elevations with an AST and an ALT in the upper 200s. Her alkaline phosphatase was mildly elevated at 170. Her bilirubin was completely normal. At this point, I think, if we're interacting, you said, what test should we do for this new twist in her presentation? And so we decided to do right upper quadrant ultrasound to see if this was related to a problem in the gallbladder. That ultrasound demonstrated no evidence of cholelithiasis. The gallbladder had a normal appearance without any evidence of interstitial edema. There was some suggestion that there was some mesenteric haziness, sort of non-specific soft finding. And given the absence of a diagnosis and the absence of complete normalcy, we decided she ought to come in and at least get observed overnight. And that's when a positive test returned. And that positive test was a positive COVID test, which had just been obtained as part of the routine admission as she was coming to the hospital. And so several questions were sort of raised by this. Is this COVID? She had no respiratory things at all. Most of us, if not all her symptoms, were all gastrointestinal in nature in somebody who already had a long-standing GI problem. And so when one takes a look at some of the experience around the world, it is clear that there is a subset of patients who have primarily GI problems and may or may not manifest pulmonary symptoms in addition to that as their own way of manifesting COVID infection. So let me take a few minutes and talk about that, what we've learned primarily from the Chinese. Some of that is American, but mostly Chinese. Looking at a meta-analysis of all the work and pulling together about 10,000 patients from the initial Chinese Wuhan and subsequently the Hong Kong patients. They found that when in looking at a little over 10,000 patients, 10,686 patients, there's about a 10% prevalence in that group of primary GI symptoms as the major drivers of the COVID infection. Within that 10%, looking at the symptom complex, anorexia was by far the most common symptom, with 27% of patients manifesting anorexia. This was not broken down into whether there was dysgeusia and anosmia. And you remember our patient must have had some measure of anosmia, hence our quote unquote kitchen accident. This may contribute to the anorexia. Diarrhea is the second most common. At about 12% when you look at studies, some have said it as high as 20%. Abdominal pain, as she had as the presenting symptom, seen in about 9% of patients, and the same number of patients may have abnormal liver function tests. Obviously the intersect of abnormal liver chemistries and abdominal pain often has us thinking about biliary problems, but I think that it's reasonable and some awareness that there might be. I think, Prad, I think there are a few questions. I don't know if you're monitoring that, if I should carry on or.
Yeah, no, please carry on. I will monitor the questions.
Thank you very much. Thank you. Thank you. And so it was very important. It was very also instructive from these studies that the RNA of the virus has been isolated in the stool of many patients with GI manifestations. also in the stool of patients without GI manifestations, but clearly almost in a 1.5 to 1, it is more common in those patients who have a GI manifestation. These manifestations have also been associated with worse outcomes in patients. I think this is probably intuitive that this, I think GI manifestations likely are often a surrogate for the degree of viremia. And I'll show a quick cartoon to show what happens. And clearly, I think the more viral burden you have, the larger, the more likely that you'll have a significant infection and perhaps a worse outcome. This is what happens. I won't bore you with the pathophysiology on the, you can sort of see electron micrograph representation on the left upper corner, trying to make sure that this is not hiding it. And basically, there is virus, if you will, in the crypts of the intestines, and this is you can sort of see these RNA particles in the crypts, and patients through endocytosis may share virus between this and the bloodstream, probably through the portal circulation, and this endocytotic process then leads to the, to many of the things that we see, and the 4 things that we see GI-wise with COVID. We've already talked about anorexia, abdominal pain, diarrhea, and abnormal liver enzymes. And so there is this interplay between the bloodstream and the GI tract that is not being well worked out. I think we are beginning to understand it more. Some of us will recall our second-year pre-clinical studies with tight junctions and potential spaces in the GI tract. And I think that this is, again, coming to become just as relevant as it might have been when we're medical students. A few more things that are important. Let's see, okay. Again, these are the major manifestations. I think we've gone over them, so I won't bore you with them. But just one more tidbit, and I hope that this engenders some conversation, is that apart from our patients, when we take a look at patients who are being treated for one GI illness or the other, the presence of proton pump inhibitors therapy changes the microbiota and changes the small bowel microbiome ecosystem. And the presence of a proton pump inhibitor makes patients more susceptible to developing COVID infection. And this is very interesting. And it's important with these things to always know that association does not mean causality. And one of the major things that you're looking for with causality is to see if there's a dose response relationship. And here it is. So patients on a single dose of proton pump inhibitor therapy, the maximum likelihood estimate in terms of the odds ratio of developing COVID is about 2.2. For those on double dose PPI, the odds goes up. It doesn't quite double, but it goes up to 3.7. And this, the authors try to adjust for confounders. But this is interesting, something to think about. This is especially important for those patients who are in nursing facilities where there is a high transmissibility of COVID. I would also say that the converse may be true, and that for the H2 receptor antagonists, the data is not well worked out, but it seems that they are helpful rather than hurtful for patients who have COVID. But I think this short part of this case clearly demonstrates that there is an interplay between the gastrointestinal tract and COVID infection. And this is not because we want to be left out of this awful pandemic, but I think that's something that's quite important for patients who may show up with GI symptoms or patients who are at risk who have GI problems. I think thinking about their PPIs is one thing that you may want to do in addition to the things that Prad already talked about: social distancing, masking, and hand washing. So our patient did well. It was a rather uneventful course. Abdominal pain resolved, subsequently discharged home, and we began to face again the primary problem. She had her outpatient workup. Remember, the capsule had been administered during the previous admission in the hospital. The first duodenal image was seen at 31 minutes. Remember that this technology is passive and driven by peristalsis. The first cecal image we got at 5 hours and 47 minutes. Blood was seen at 3 hours and 31 minutes, suggesting that this is likely in the proximal 60% of the small bowel. There was no clear source identified. We really couldn't see from the capsule what was bleeding, just the presence of blood. And after we were sure that the capsule had passed, she had an MR enterography, and an MR enterography is like CT enterography, only done by MR. It looks at the small bowel and tries to optimize the imaging of the small bowel. And it demonstrated a hypervascular focus measuring about 2 centimeters in the proximal to mid-ileum, more likely in the proximal ileum. And so this gave us a clue that for the last close to a decade plus, that she may have had something that's been growing there and bleeding intermittently. And so decided to focus on this and see if we could identify the source of this palaver that she'd had for just about 12 years. So we now have this ability to perform long forays into the small bowel. I remember as a child wanting to go into gastroenterology, and my old man, Patrick, the older Patrick, saying that the small bowel is often like Australia. You have to make special arrangements to get there. But we now have those special arrangements in our purvey and available here within our system. And we performed a single balloon enteroscopy. This is a balloon augmented long endoscopy, which allows us to travel through the small bowel. And we were able to get to the proximal ileum, approximately 3.5 meters from the pylorus, and found a large ulcerated mass in the proximal ileum. There was no stigmata of recent bleeding. The mass appeared largely subepithelial, meaning that we saw a bump. The bump was clearly mass-like, but a lot of the epithelium covering the mass appeared to be normal, except for this area of small ulceration. Based on its appearance, we did not make any attempts to resect this, which we're able to do when it's appropriate, because this is largely below the mucosa and not above the mucosa, and thought that this is more likely a surgical issue as opposed to one that we could treat endoluminally. We marked it with a submucosal tattoo. The submucosal tattoo allows for, excuse me, easy surgical identification at laparoscopy or laparotomy. This is what it looked like on the enteroscopy. You can sort of see that there is something pushing the mucosa, if you will. These are different aspects of it. Clearly this it was not bleeding at the time, but we very much saw that this corresponded to what was seen on the MR enterography, and very likely the cause of her intermittent bleeding over several years. So let me take a quick 10 minutes and get through some of the aspects of the GI aspects of what this was and how we got to it, and just leave some time for conversation. This was at surgery. This was done laparoscopically. Thankfully, the submucosal tattoo allowed for this, because the surgeon is denied the chance for he or she to palpate the intestines. So the submucosal tattoo is very good for the identification. So this was done laparoscopically, completely excised, did not appear to involve the mesentery. And so, excuse me, the things that were found on the previous hospitalization may have been due to her incidental COVID infection. The mesentery looked absolutely normal at surgery. By immunohistochemistry, this is found to be a gastrointestinal stromal tumor. Prad will be quite familiar with these. It also fulfilled the diagnosis by microscopic criteria. She was discharged very quickly. She was a very fit lady and was able to go home. She had a primary anastomosis. She was able to go home after 72 hours. Because of the size of the gist and because of the criteria on immunohistochemistry, she was referred to oncology. This was not the sort that we thought should be managed expectantly. There were too many mitotic figures. If I recall, I think she had 7 mitotic figures per high power field. It was clearly a 5 centimeter mass. And so this really required for her to see the oncologist. Anyway, it's been 9, now 10 months. She's been completely quiescent from the GI standpoint. That anemia, which had been with her, has now resolved. And so I think this just sort of leads me to describe how we now look at GI bleeding. We used to describe upper GI bleeding in a little more complex fashion. Now we say it's from the mouth to the ampulla vata. Mid-gut GI bleeding is from the ampulla vata to the ileocecal valve, and lower GI bleeding is everything distal there. Most mid-gut bleeding is from the small bowel. 90 to 95% of them come from the small bowel. It's common, it's vexing. The median time to diagnosis is about 2 years. The average patient costs about close to $35,000 in terms of the workup because of the difficulty in finding the cause of bleeding. And on the average, looking at a Medicare cohort, they get at least 7.3 tests, mostly endoscopies, per patient prior to a diagnosis. So there's been a bit of a paradigm shift since the advent of video capsule enteroscopy and double balloon and subsequently the other forms of enteroscopy. Let me go through them very quickly so that we can leave some time for discussion. In 2005, Hironori Yamamoto, who's a Japanese gastroenterologist who's become a friend of mine over the years, while he was doing a sabbatical in Texas, thought about using a balloon attached to a scope to look at the small bowel. This is a 2-meter long scope. It has an overtube. It has a balloon at the end, which you see being deployed here in the cartoon. Then there's an overtube that follows, and that also has a balloon. Those 2 balloons are then used to pleat or squeeze the small bowel, if you will, almost like the drawstring on your scrubs, allowing the scope to make further forays into the depths of the small bowel. So this then followed in 2007, and I was approached by Olympus at the time to bring this into the North American market with others. This uses it's also a 2-meter long scope. It has a single balloon. It doesn't have a balloon at the end of the scope, but the scope here is very flexible, so it's able to hold just like the balloon. And we do the same and make further inroads into the small bowel. This is the spiral enteroscope, and the spiral enteroscope uses also a 2-meter long scope. This is, I think, what the future, this will probably be here post-COVID. We've been working on this for several years. It uses a motorized spiral, and the idea is to use a motorized spiral and also pleats the small bowel in this fashion. So this is a battery-operated remote control spiral. The preliminary results of this appear to be quite good in terms of the depth of insertion and the absence of injury to the small bowel. So what I've shown you in the last 3 slides are 3 different ways that we're able to get through the small bowel. We're able to do this largely from the mouth, as well as from the colon. It is technically more difficult to do from the colon. And I personally prefer to use a different method, different from these 3 methods, to perform a retrograde or through the colon method. But we won't get into that. So clearly the need for this therapy was, or these techniques are important because of patients like the patient I just presented. We needed to treat these patients. We needed to understand what is causing their problems. So we're able to do tissue sampling and able to navigate the small bowel for all sorts of things. These are the things that are available in 2020, and like the Masters competition starts today, and like a golfer, I don't play golf, but like golfers, there are different things in the armamentarium, and you try to approach people with some of the things in the armamentarium. I'm looking at the time. I will present for exactly 7 more minutes so that we'll have time for questions. The way that we decide how to go is to look at the capsule, look at at times we go from the mouth. If it's in the latter 1/3 or the distal 1/3, we go using a retrograde approach. When we combine video capsule and then DBE, the yield, when you look at them, the diagnostic yield is the same for both of them. So one isn't better than the other because there are things that each of them misses that the other sees. But when we combine both of them, this is really when we get the very best outcome. And the reason for combining both of them is, and the improvement in the performance, it's probably because we have a target to look at. I've sort of scratched my head over the years why there is this 19% improvement. And I think this is a long and tedious procedure. And as you look, and if you're looking for a needle in a haystack, you probably likely persist more when you know that there is definitely a needle in that haystack. And so there is about a 19% differential improvement when we do the capsule before and have some pre-idea that there is some GI pathology there. And so when you look at that, the number needed to treat, or the NNT for that, would be about 1 in 5, which is fairly powerful. So I think wherever possible, it is reasonable to perform the video capsule to give the enteroscopist a target, and also the wherewithal to make the right decision so that she or he can decide whether to go from the mouth or to go through the colonic route. Yes, so we've talked about this. Just bear with me. I think I'm going backwards now. So this is the other method I was trying to talk about. This is the method that I think which shown in studies in the paper that I'd published with some colleagues when I was still in Baltimore. This method is better, and it's different from the other methods. It uses an Israeli developed through the scope tube, and you can see the balloon here. It's in the small bowel. We use it, we anchor, and you can see what happens, and you pull that towards the scope and get deeper and deeper. And we use a standard colonoscope for doing this. So this is our preferred method. We don't have this at RGH yet, but we have the scopes. All we're hoping to do is to get the balloon and then to carry on. The kinds of things we see: neuroendocrine tumors, juvenile polyps, and so on. These are the kinds of things that we're able to do to treat bleeding. You can see an ulcerated bleeder here, and we're using argon plasma coagulation to do that. In this case, this is actually post-resection, and we're just using that. This is the passage of a monopolar current through a puff of argon gas, and it's able to transmit to the tissue at a very controlled depth. And so training, we want to talk about, and what about enteroscopies? Enterographies, we've talked about this, is a very useful modality. I think it's important to have, to discuss with radiology as to the better one, CT versus MR. I think this would be institution dependent. Here at RGH, we've been using mostly the CT enterography to help. We find that using carbon dioxide, which we now use for all endoscopies, using carbon dioxide helps us to get deeper and deeper. And so this is an important sine qua non for doing any enteroscopy work. So I will stop, as many of these are now sort of GI specific, but before I stop, it's important to, not like a snake oil salesman, talk about some of the adverse events which may occur from this deep forays into the small bowel. There is a perforation rate which is between 1 in 1,000 and 1 in 5,000, but that perforation rate goes up to 3 in 400 if the patient has altered anatomy. Unfortunately, many of the patients that get sent to me for ERCP and other things, including last night I did such a patient here at RGH, are patients with altered anatomy. So we have to be careful with those patients. Bleeding can occur, particularly as you're treating these lesions. This is important for patients on LVADs. LVAD patients have a lot of angiodysplasia. As you treat them with argon plasma coagulation, you don't want to ulcerate the adjoining or the adjacent tissue. Bacteremia may occur, and that's usually transient. It's important. We think there's sometimes unclear bacterial translocation, and patients may feel feverish or have shaken chills. This often goes away. We have to be careful in IBD patients. They're certainly more fragile and more likely to undergo sustain mural injury. And as I said, carbon dioxide is important for all sorts of reasons, particularly performance reasons, and for keeping patients comfortable. For a long time, you really couldn't do these procedures because patients would be so terribly bloated after the procedures. CO2 has made a difference on so many different levels that it's important. So in conclusion, I think we present a case of some of a patient with difficult to find obscure GI bleeding, identified to be coming from the midgut. And this well-identified clinical need, which we see in about 5% of patients with GI bleeding, was addressed using present available technology in an iterative fashion. And this time we were lucky that the technology worked in the way that it should. It was thoughtful. We used these sequential decision-making to get there. We were thrown off during the patient's course by the development of COVID, which presented with GI-specific symptoms. However, this did not have anything to do with a prior problem nor the outcome of the present problem. I thank you for listening to me and muddling through this case with me. I think I've, at Prad's suggestion, left some time for questions since we're not in the same room. And so he's going to shepherd us through that. But thank you very much indeed.
Thank you, that was wonderful. So I had a question. You said the instrument is 2 meters long, is that correct?
That is correct, yes.
Yeah.
So the average colonoscope, just to give you, is about 1.6 meters to 1.7 meters long. The longest colonoscopes we have are 180s, and that's 1.8 meters. So it is not terribly longer than a colonoscope, but it is clearly longer than a colonoscope.
Yeah. And what is the length of the small bowel?
Oh, it's about 6 meters on the average. Yes.
So you get to the first 1/3 if you go the upper route. Is that about
that
right?
is correct? And then you continue to augment. So the average depth of insertion for these is about 2 2.75 to 3 meters. The US multidisciplinary study suggested they got to more than 3 meters. And then you try to get to 1.5 meters the other way. And in about 40% of circumstances in Asia and about 20% of circumstances here in America, you're able to cross where you go from on top and where you go from the bottom. We know that by tattooing, so that's called a pan-enteroscopy, but it happens in the exception as opposed to the rule. It's easier in Asia because I think people have much less mesenteric fat, so you're able to pleat the small bowel much more readily than here in North America.
I see. So usually there's an area of the small bowel that you'll miss, even looking from.
Yes, I think that there is averagely, 1 to 1.75 to 2 meters that you may be blind to. However, most of the pathologies we usually quite find in those areas that we are able to access. So this is largely made intraoperative enteroscopy, which we used to do all the time, almost a dinosaur, almost something that we never do.
Right. So one of the questions online here is, to avoid delay in diagnosis of middle GI bleed, when should we pursue this type of evaluation and spare patients from repeated EGD and colonoscopies?
This is such a fabulous question, and a question that's driven by the literature. It's driven by the literature in that we also achieve greater diagnostic performance when we have this kind of parsimony, if you will. So in an ideal circumstance, we would do an upper endoscopy and a colonoscopy, and if this was negative, we would drop a capsule at the time of the procedure. We are, however, inhibited by many things, many logistic problems. And the logistic problems we're trying to solve, some of them have to do with payers, some of them have to do with the ability to provide this technology on an inpatient basis. It requires some simulation, if you will, by the nurses who do it, the ability to drop it at whatever time of day that it is, and then take care of the recording equipment. So these are things that the people who are our clients, which are our colleagues and patients, don't want to hear, but it is challenging to get all those things together. But the ideal circumstance is one where we have solved all those problems and immediately there isn't an answer. We're able to do it, even sparing the patient to the sometimes difficulty of actually swallowing the capsule. But we're faced with many challenges which we're trying to solve. And I can assure the audience that we will work through them, and Rochester Regional will be an example in terms of being able to solve these and be able to avoid some of the long workup that we have in patients who are frustrating like she was.
So another question here is it known what is actually causing the abdominal pain in COVID patients?
No, this has been the subject of great conversation. It isn't. One theory is clearly that there is microangiopathy, and that this microangiopathy may be due to what COVID does to platelet aggregation, etc., and that the blood flow to the mesentery may become sluggish. But this is a theory. It's a theory that may or may not be ever proven. But clearly, in patients who have lots of the virus in their GI tracts, we see evidence of microangiopathy. This might be what's driving the pain.
Or it might be bowel spasm, don't you think?
It certainly could be, except that we're going a little bit away from bowel spasm in that bowel spasm we now see as a motor event. And so there has to be something on the sensory side that is causing it. So it could be something that's happening at the time of bowel spasm, such as bowel edema. So Prad, you may be right from that point of view. That might be what's driving it. It tends to go away, and I think this has sort of largely tempered some of our enthusiasm for looking at that. That's another great question.
So Dr. Dixon Gordon asks, has there been any evidence of COVID causing esophageal pathology or symptoms?
No, not that I know of. And please forgive my naivete if there's some report somewhere. But I'm a disciple of the literature, I think, and we haven't seen evidence of that. We know of viruses that affect the esophagus, mostly hepatic viruses and the like. But no, not in COVID. We haven't seen it. At least it's not been reported. It might be there somewhere.
Yeah. Dr. Jadhav asks, how long does it take to do an enteroscopy and how much time to read a capsule endoscopy?
Excellent question. This is part of the logistic difficulty. So you can imagine that a capsule study is on the average an 8-hour study, 4 frames per second. It is a tedious thing. It is a tedious thing. On the average, it takes a gastroenterologist, about an hour and a half to 3 hours to read a capsule study. It's a tedious thing. It's a labor of love. And the easier that we make it for the gastroenterologist, the more likely we get a thorough read. These are the things that we're talking about. The average enteroscopy is also long. This is why it's often done under general anesthetics. In the studies that I did while I was in Baltimore, the average procedure, the median time for a procedure was 41 minutes. But the average was over 65 minutes. And that tells you that some of the procedures were really, really long. And that really influenced the average. The reason why the median was more modest is there are times, especially in LVAD patients, when you run into the pathology early in the procedure. So they are long procedures, and I don't want to minimize some sort of, how much stamina that they require.
Yeah. Is there anyone using AI in?
That has been brought into play. Can AI find these angiodysplastic lesions both at the capsule stage and the enteroscopy stage? We've been able to identify them for solid lesions. So AI has been in play now in GI, and for some reason outside of North America, people are much more interested than we are. But AI has come to GI, and we hope that it becomes ubiquitous, if you will, in GI as an adjunct to help us with identification and decision making. But AI is a very strong focus of development and technology. Yes. So excellent question, Brad.
Yeah. So Dr. Huzzleton says he had 48-year-old man with bowel obstruction and perforation. Can COVID cause an SBO?
Dr. Hazelton, I can see how it will do that theoretically. I haven't seen it. It wasn't reported in the Chinese studies. It wasn't reported here. I think it's more likely to cause an adynamic ileus before it causes an obstruction. I guess it could potentially cause an obstruction if there was much lymphatic or lymphatic reaction. It's just not been reported. And again, I always have to answer some of these questions with humility because we are in the first year of our knowledge with this, but it's not been reported in the regular literature.
Mahesh asks, with the new definition of middle GI bleed, where will hemosuchus pancreaticus fall, as the bleeding will be through the ampulla?
Mahesh is a troublemaker. Mahesh, thank you so much for that. Haemosuccus pancreaticus is just right at the no man's land, in that it is right at the ampulla of Vata. I suspect that you would still call that upper GI bleeding. It is within the reach of a regular endoscope. It often escapes detection because of where it's coming from. So I think definitely Haemosuccus pancreaticus would still be upper GI bleeding. Everything after the ampulla of Vata clearly would be midgut.
Right. And then the last question from an anonymous attendee here is, do we have evidence available for use of carbon dioxide during augmentation?
During augmentation, I'm not sure I understand the question.
I'm not sure I understand it either. But
yeah, but let me talk about carbon dioxide generally. Yes, carbon dioxide is important first, and we got interested in it just because patients were more comfortable than air. So in the old days, in endoscopy units, the nurses were very good at trying to recover patients, massaging patients. Patients would be quite bloated because of the presence of air. And this was standard endoscopy. So you can now imagine a procedure that's 3 or 4 times longer than a regular endoscopy, that the volume of air would be much more significant. So this is what got us interested in CO2. You do lose a bit of, pardon me, a bit of the distensibility, but not much. But you gain this ability that patients tolerate it, but at the same time recover faster and so on. But then it then dawned on some of the early investigators that because the carbon dioxide does not get into the interstices, into the interstitium of the bowel, that the balloon works so much better. And so when you pleat or full the balloon at the bowel, you are doing a much better job. And so the depth of insertion was compared air to carbon dioxide, and carbon dioxide is by far the better way of doing it, that it is considered a poor quality examination to do with air. So even beyond the question of patient comfort. Then lastly, if there is ever a problem in endoscopy and air escapes into the peritoneum or the mediastinum, air clearly results in more significant consequences than carbon dioxide. So carbon dioxide has really, for those reasons, become the platform through which we do most GI procedures. But in the question of enteroscopy, it's an absolute yes. So it's an absolute no to go away from carbon dioxide. I hope that answers your question. But that's the general gist about carbon dioxide in GI procedures.
No, that sounds like it would have answered it. Thank you very much. That was fantastic. And it's amazing that we can do these types of procedures at RGH, look at more than half the small bowel. Quite amazing. And of course, the capsule looks at the entire small bowel, tedious and occasionally misses something. But
that is correct. Yeah, that is correct. And, we've been doing that for a while, and my colleagues who are here have developed a robust program with capsule, and we hope to just make that more available and better as we work through some of the logistic issues. I'm very thankful for your time this morning. Thank you very much indeed.
Yeah, fantastic. Thank you very much.